Recording in progress.
We'll just continue our discussion related to electrolyte imbalance and regarding we just had some basic concepts about how different electrolytes are being controlled in a very narrow levels, the narrow ranges it's maintained. Okay, so just to recap, there was involvement of ADH, there was involvement of aldosterone. Okay, there was involvement of renal tubules. Okay, there was involvement of intestinal obstruction, intestinal absorption. Okay, some trans compartmental shift. Okay, and as a result of some this was a basic concept which we discussed in our discussion yesterday. So we will just try to start with sodium. Okay, so sodium usually is the main ion of extracellular fluid. Okay, so it will be maintaining the osmolarity of the plasma. So anything, if it is there is any change in sodium, will affect the osmolarity, and it will because the cells will be affected. Okay, so like if the sodium levels decrease, so what will happen, that like if it is hypoosmolarity, then more fluid will go inside the cell, and that's what happened in cerebral edema, because cells will be swollen. And similarly, if sodium levels are more, so it can cause please, if you can mute yourself, it will be good for everyone. Okay, so if sodium levels are more, so the cells because it has more effect on the brain cells are very sensitive to changes in sodium levels. Okay, so that's the reason when there is too much dehydration. Okay, so the conscious level changes which occurs are maybe related, some of them are related to this thing as well. Okay, so so another thing is a concept that there may be the total sodium in the body. This will be one thing, and the relative levels at that time in the blood, because maybe the total sodium is normal, but there is more water inside, so the level will be decreased, or there will be hypoosmolarity. Okay, and hyponatremia, which occurs as a dilution. Okay, so can anyone give an example of this hyponatremia? As an anesthetist, yes, anyone please? Dr. Dora, would you like to tell? Anyone please? Zunera, Tayyab?
Sir, SIADH.
SIADH, one of them. Okay.
And liver failure, kidney failure, and heart failure.
TURP. In TURP,
yes,
sodium levels are normal. Okay, but there is too much free water. So Qrp syndrome, which occurs, it is an example. Okay, so we will just have a look at it. So as I told you, the basic concepts are most prevalent cation in the ECF. Okay, and it is maintained between 135 to 145. Okay, and filtrated by the kidneys, reabsorbed in the, I will just show you the picture of sodium absorption and excretion. I will just open it. So over 99% of filtered sodium is reabsorbed by the proximal tubule and loop of Henle. Okay, The reabsorption occurs at relatively fixed rate regardless of total body sodium. It is a smaller portion of sodium reabsorbed in the distal tubule and collecting that. This is very distracting. I need to change the setting. I think I need to mute everyone. Or what should I do? Okay. Okay. So what happens that, as I told you, that it is filtered through the glomerulus and then reabsorbed in the proximal tubule. Okay. This reabsorption occurs at a relatively fixed rate regardless of the total body sodium. It is a smaller portion of sodium reabsorbed in the distal tubule and collecting ducts that exert the most influence on total sodium balance. Like this one is totally reabsorbed and at a fixed rate. And whatever changes occur, it is in the distal tubule and collecting duct, where ADH and aldosterone are acting. Okay, so this is an important concept. But serum sodium levels reflect water balance under the influence of ADH. Okay, so that's why when there is any head injury or anything, there is some problem related to ADH. So that will be creating the problems, the majority of hyponatremic states involve in inappropriately elevated levels of antidiuretic hormone. Okay, this causes disproportionate water retention compared to sodium. The secretion of ADH is influenced by multiple factors such as plasma, osmolality, and circulating volume. Failure to suppress ADH production is in lowered osmolality states is a feature of SiADH. So what is that? That if normally when osmolality is decreased, ADH should be inhibited. Okay, because you can say that someone is just tasting that if it is looking less salt, ADH will stop secretion. Okay, so this is if it is control, it is not going under control, it will be causing too much water with reference to sodium. So it will be resulting in hyponatremia. By contrast, continuous production of ADH despite a lowered serum osmolality is a feature of edema, forming conditions such as heart failure. Okay. In that condition, ADH is creating the edema. In later conditions, ADH production continues because reduced renal perfusion causes excess aldosterone production. As it occurs in heart failure and liver disease, there is hypoperfusion. So aldosterone is being released and is causing more absorption of water and salt. Okay. True hyponatremia is recorded as low sodium level in presence of high osmolality. Okay, so this is the true hyponatremia when there are no low sodium levels itself. Hyponatremia in the presence of high normal or high serum osmolarity can occur. This is known as hyponatremia. Okay, pseudo hyponatremia. Can anyone has explanation for this thing? Any condition in which there is hyponatremia, like total sodium is less, but osmolarity is more. Yes, please.
Sir, HHS.
Sorry?
HHS, hyperosmolar hyperglycemic coma.
Yes.
This is hyperglycemia.
And what about this one, cerebral salt wasting syndrome?
Okay.
No, I'm asking you. What
Sir, no, I don't have more knowledge about cerebral salt wasting.
I think in salt wasting syndrome, water will also be reduced. So there may be in some conditions, osmolarity may be normal or even high. It may be, I think, if I'm not wrong, let us just continue and discuss. As sodium and its accompanying anions are the major effective plasma solute in the ECF, hyponatremia and hyposmolarity always coexist. True hyponatremia is regarded as a low sodium level in the presence of hyposmolarity. The situation in which hyponatremia can occur without hyposmolarity, I'll discuss later. True hyposmolarity, as I told you, then sodium is less. Okay, let us see the just a second. Okay. True hyponatremia is characterized by hyposmolarity. This is because sodium in the ECF and potassium in the ICF, along with their associated anions, determine osmolarity. This is with which mechanism maintains this sodium balance in ECF and potassium balance in ICF. This is sodium potassium ATPase. Okay, with water moving freely between fluid compartments. In order to maintain the same osmolarity between compartments, as a result, plasma hypoosmolarity and therefore hypotonic hyponatremia indicates a relative excess of water to sodium regardless of volume status. I repeat, it as that when there is plasma hyposmolarity and there is excess of water regardless of volume status. Like maybe a patient is hypovolemic, okay, but relative water levels are more and there is hyponatremia, okay. It is an oversimplification to regard hyposmolar states as produced by either water excess or solute depletion, as often components of both are involved. It can be useful though to classify hyponatremia on the basis of fluid status. This can facilitate understanding of the processes involved in the development of hyponatremia and also help guide management. So either it will be hypovolemic, euvolemic, or hypervolemic. Okay. So what happens in hypovolemic? Total body in hypovolemic hyponatremia, total body water and total body sodium both are low, but there is disproportionate loss of sodium compared with water. Okay, I think this should be cerebral salt wasting. Let us see what are the. This is the result of increased ADH secretion seen in hypovolemic states, causing increased water reabsorption. Okay, so in this hypovolemic hyponatremia, both there are like body water and sodium both are low, but there is sodium is more loss as compared to water. Okay, hyponatremia is often compounded by thirsty patients consuming hypotonic fluids at a level inadequate to try to restore circulating volume. So this is iatrogenic. Okay, and if someone is taking too much water. Sodium loss can be renal or extra renal, and establishing the urinary sodium level is important in making this distinction. Urinary sodium level below 20 millimole is suggestive of an extra renal cause. Okay, extra renal cause are usually GI, when other causes include exercise and associated hyponatremia, when a patient has too much sweating, burns, trauma, pancreatitis, and renal causes include excessive diuretic use, renal failure, and salt wasting nephropathy, aldosterone deficiency, chronic pyelonephritis, nephrocalcinosis, proximal renal tubular acidosis, and ketonuria. The basic concept is that if serum, urinary sodium levels are high or normal, sorry, sodium levels are low, then there may be extra renal cause. Okay, because if sodium is excessively lost, then it is related to kidneys. But if it is urinary sodium levels are low, and so it is warranting some extra renal causes of GI origin. Okay. Okay, euvolemic hyponatremia is the most common category of hyponatremia seen in hospital patients. Okay, SIADH is most common cause of euvolemic hyponatremia, and it is associated with many different disorders. Like these can be divided into if SIADH is suspected, it can be useful to measure urine osmolality. As a urine osmolality of more than 100 milliosmol per gram is in the presence of hyponatremia reflects inappropriate antidiuresis. Okay, so water is being reabsorbed more. So if water is reabsorbed more, then osmolality, urine osmolality is more. Okay. As SIDH remains as a diagnostic exclusion, other potential cause must be investigated and excluded first. So, patient taking diuretics, CNS disorders, okay, pulmonary disease, I think. Okay, other common causes of euvolemic hyponatremia include glucocorticoid deficiency. Cortisol deficiency may lead to failure of ADH suppression. Okay. Usually there is a feedback control. So when it will be not there, in hypothyroidism, there is hyponatremia secondary to hypothyroidism. Okay. It is thought to result from impaired water excretion due to decreased GFR, secondary to systemic effects of thyroid hormone deficiency on peripheral vascular resistance and cardiac output. Low solute intake beer, I have no idea about it. The beer potomania, where the primary abnormality is not one of water balance but sodium balance due to reduced intake. Okay. In hypervolemic hyponatremia, this is characterized by paradoxical increase in total body sodium, but a simultaneous and proportionally larger increase in total body water. Okay, leading to a dilutional hyponatremia. This reduction in water excretion is secondary to either an excess of ADH secretion or an element of renal impairment, limiting the maximum excretion of free water. As occur in congestive renal failure, actually gradually the ability to make concentrated urine is lost. Okay, so patients are actually losing sodium. So this is one of the usually water is in excess, but the kidneys are unable to absorb sodium. Okay, so as occur in nephrotic syndrome, congestive cardiac failure, cirrhosis. What is the pathophysiology of hyponatremia and liver? We discussed before. Okay, in all these situations, there is edema secondary to impairment of kidneys' ability to excrete water maximally. This results from either inappropriate ADH secretion leading to water retention or an inappropriate distribution of fluid within the body, preventing intravascular fluid elimination. Okay. So what are usual symptoms of hyponatremia? Because it is one of the most difficultly treated thing in ICU. Okay. In ICU, which sort of hyponatremia is being seen usually? Because as I told you, whenever there will be a decrease in consciousness. Okay, the symptoms and signs associated with hyponatremia relate to both the degree of imbalance and the time course over which the imbalance has developed. Neurological symptom can occur as a result of osmotic gradient between the intracellular and extracellular fluid compartment. This gradient causes water to move into the cell, resulting in tissue edema. As I told you that if sodium will be low, what the as this thing I told you, this is the most important thing. Then whenever there is hyponatremia, water will be going from the ECF to the cells, so it will be causing edema. Okay, this gradient causing water to move into the cell, resulting in tissue edema. This process is clinically most important in the brain, as I told you. Okay, due to exhaustion of adaptive mechanisms and confinement of the skull, cell swelling here can lead to raised ICP and neurological damage. And the thing which is on the basis of this concept is Monroe Cali Doctrine. Okay, so whenever there will be swelling, one thing, the other thing should be compensating. Otherwise, ICP will raise. There are three things: CSF, blood, and cell, brain tissue. So if brain tissue will be edematous, ICP will raise, and there will be neurological damage. This situation occurs most often when hyponatremia develops over a short time frame, acute. If severe hyponatremia develops over the course of hours or days rather than over many days or weeks, then the ability of brain to adapt osmotic changes and cell swelling is more rapidly is more like there may be some compensation. That leads to development of cerebral edema. Okay, patient in home acute severe hyponatremia has developed and under 48 hours can present with alarming neurological findings such as coma, convulsions. Okay, the same thing which we face in Qrp syndrome as well, because that this absorption of water is acute. Okay, rapidly evolving severe hyponatremia in a different disease entity from slowly, so brain adaptation occur. So how will it be investigated? Clinical features will be there. Okay, and then there may be some cause, there may be some involvement of there may be some head injury, so it is related to that one. So it will be a brain radiological study and urine osmolarity and plasma osmolarity. Okay, so thyroid function test and this one different hormones. Okay, so this is what we have discussed. Osmolarity is decreased. Hypotonic hyponatremia, this is true hyponatremia. Okay, total body water is decreased and total body sodium is increased more, decreased more than total body water. This is hypovolemic hyponatremia. And in that one, if it is extra renal loss, the urine osmolarity will be less than 20 millimole, vomiting, and there is extra renal loss, vomiting, diarrhea, burns, bowel obstruction, pancreatitis, trauma, excessive sweating. Okay, and if it is more than 20 millimole in urine and sodium, so this is related to diuretics or renal failure. As I told you, that kidneys are unable to reabsorb the sodium because the nephrons are damaged, and mineralocorticoid deficiency. Okay, this one aldosterone deficiency, chronic pyelonephritis infections, nephrocalcinosis, proximal renal tubular acidosis, ketonuria. So in this one there is hypovolemic hyponatremia, which is the true hyponatremia. Okay, the volume is also less and water is also less. Okay, but sodium is lost more than water, so that's why the osmolarity is low. So that is the concept. Okay, low osmolarity, hypovolemia, so water is decreased but sodium is decreased more. So that's happened. So how will you treat it? We will whenever we want to treat hyponatremia, the basic principle is that you should not be correcting it very fast. This is one thing, and the option will be either normal saline or hypertonic saline. okay, and stop the cause. If you can, this one, the diuretics, if you want to stop it, okay, and then you will be restoring it with normal saline. And if it is chronic, you don't need to give hypertonic saline. You can use normal saline for this purpose. Okay. So again, because it's very complicated and it is very difficult to explain, but I'm just trying to do as much as is in my capacity. So, but this is how you will be treating it. Then if the osmolarity is more, like in that condition, sodium is low, but osmolarity is high. Okay, that's what you told this condition, hyperosmolar non-keton, this non-ketotic coma, okay, diabetic coma. So similarly in with use of mannitol and glycine. With mannitol, how it occurs? I don't know with how. It is sorry.
Sir, intravascular water retention.
No, not water retention, because it is itself is very highly osmolar substance. This is the reason, I think. So transiently, it will increase the osmolarity, and then it will extract water, and that's why with mannitol therapy, patient can go in pulmonary edema as well. Okay, so that may be the reason. Okay, so hypervolemic hyponatremia, urinary sodium usually less than 20 to 30 mole due to activation of renin-angiotensin-aldosterone system with secondary renal sodium conservation despite the whole body overload that is occur in this CCF and cirrhosis and renal failure, as I told, as we discussed before as well, that despite volume overload, body is just conserving more salt, but water is more. So still there is hyponatremia. Okay. So CCF, cirrhosis, nephrotic syndrome, treatment, fluid restriction. Okay. Chronic and acutely hypertonic saline and loop diuretic. Addressing underlying disease, restrict salt and water intake. So they will restrict the source, and they will just try to again that treating any hyponatremia, the basic principle, again I repeat, that it should not be corrected very fast. Chronic, correct by 6 to 8 millimole per day. Caution of patients with severe malnutrition, alcoholism, advanced, need to target 4 to 6 millimole per liter per day. Okay. And the last is one when there is no osmolarity is normal, and there is a volume, body is euvolemic. Okay, so water is increased and sodium may be normal. So total sodium total body sodium is normal, but there is excess water. Okay, so that is what occur when we take more water. Okay, polydipsia, and in which urine osmolarity more than 100 reflects inappropriate antidiuresis. Okay, as occur in syndrome of inappropriate ADH, in which water is this too much absorbed and it is osmolarity is more. Okay, and urinary sodium is also more. So what to do? Again, fluid restriction, treat underlying cause, assess chronicity of disturbance, and treat as below. 100 ml hypertonic saline is only used in acute setting. Otherwise, usually restriction and diuresis and normal saline may be used usually for whatever the cause is. Usually the mechanism will be the same. Measure sodium every 1 to 2 hours. Consider loop diuretic to enhance free water clearance. Okay, in this type there will be need of diuretics more than others. Okay. So general advice, again, overcorrection will cause, if you overcorrect hyponatremia, what will happen? If you give suddenly, the same thing will occur, which is demyelination. In that way, that when if you are giving hypertonic saline fast or more rapidly, so water will come out. So it will cause demyelination. Okay.
Yes, sir. Pontine
Central
myelinolysis.
pontine myelinolysis. Okay, that is the condition which can occur. Okay, so the same thing they have written, I think. Presentation is usually delayed by 2 to 5 days following correction. Osmotic demyelination diagnosis may be very difficult in sedated and ventilated patient. That's what I told you, that in ICU, hyponatremia and hypernatremia both are killer, because patient will not be able to get up if the sodium is not balanced. And actually this is the least we are taking lot of care about treating infection, ARDS, VAP, and etc., etc., etc. But if you see, either it will be high or it will be low, and people are missing it. And actually in some condition it is very difficult to treat. Okay, because there is no clear diagnosis, and if you are using some medication, there are other effects are coming. So sometimes it becomes very difficult. Like for example, in other hypernatremia, if you are giving, if patient is acidotic and you have to treat the acidosis, like indication of this one soda bicarb. So a patient is already hypernatremic, though it is very difficult, because the solution which is used in that condition is called THAM solution. There is what I don't know the abbreviation. This is THAM solution to treat metabolic acidosis, and it is divided. It does not have the effects of this hypertonic soda bicarb which we have to give in that condition. Okay, so this is an example. So in ICU, it is very difficult. Recommendation for the rate of correction are based on avoiding brain herniation, something that is almost exclusively seen in acute hyponatremia. These patients have the greater risk of cerebral edema, but a lower risk of demyelination when compared with chronically hyponatremic patients. Acute, okay. Therefore, prompt partial correction of hyponatremia is indicated. Limited available at suggests 4 to 6 millimole per liter to exceed the Caesar threshold of 120 millimole is adequate to reverse the most severe manifestation of acute hyponatremia. Okay, so in acute hyponatremia, severe neurological may be treated with the bolus of 100 mils of 3% hypertonic saline. Okay, and then repeated. And actually the main thing will be serial measurement and gradually correcting it. Okay, so actually it is the same thing which we have already discussed. We will just try to have because the basic principle is that whenever you have any either it is excess or decrease, I tell you that you will be calculating the sodium levels. Okay, and then you will try to bring it towards the normal level. If it is, you will be bringing, and if it is more than 150, you will be in a gradual way. Okay, so actually this topic is very difficult. I always try to avoid and run away from this topic. I have limited knowledge for it. I just try to it, and we will just continue hyponatremia inshallah tomorrow. Okay, and I will try to sum of the basic summary was whether there is one thing which is volume status, the other thing which is osmolarity, and the third thing is the actual sodium levels. Okay, and we have to treat it either with fluid restriction, with diuretics, with this one hypertonic saline, or normal saline. Okay, so thank you very much. Inshallah, we will continue the rest of sodium balance tomorrow, inshallah.